of breast are classified or categorized into 4 categories. These include the congenital diseases, inflammatory diseases, which include infective, non-infective. The infective divided into acute and chronic mastitis. The non-infective inflammatory diseases of breast are divided into ductectasia, fat necrosis, and galactose. The third class is fibrocystic disease or fibrocystic change, which are divided into non-proliferative and proliferative diseases of breast. And the fourth category is tumors, which are divided into benign, malignant, and stromal tumors. Let's start with the congenital anomalies. This includes ectopia, accessory breast tissue, and congenital nipple inversion. Ectopic breast tissue can be seen in nipple, axilla, axillary lymph nodes, chest wall, and vulva. In accessory breast tissue, usually it is present in the axilla. And microscopically or histologically, it contains the same breast tissue in the normally located breast. Congenital nipple inversion, here its importance is to differentiate between congenital nipple inversion and the nipple inversion or retraction of the nipple that is occur in malignant conditions, in carcinoma. The inflammatory diseases of breast include, as we mentioned, either infective or non-infective. The infective include acute mastitis, breast abscess, and chronic mastitis, which include chronic non-specific mastitis and granulomatous mastitis. In acute mastitis, it can be either localized or generalized inflammation of the breast, and it can be precipitated by trauma or lactation. The most common causative microorganism is Staphylococcus aureus, and less commonly it can be caused by Streptococcus pyogenes. Commonly can lead to cellulitis. Chronic mastitis and granulomatous mastitis. We have in chronic mastitis, we have chronic non-specific mastitis, and we have granulomatous mastitis. Here are the causes of granuloma in breast. At top of list we have tuberculosis. In TB there will be caseating granuloma, giant cells, epithelioid cells, plasma cells, and lymphocytes. In fungal infection, we have a special stain for fungal infection. We can see the causative microorganism. Sarcoidosis is diagnosed by exclusion, and there is no special laboratory test for diagnosis of sarcoidosis, and really it is rare disease in Iraq. Idiopathic granulomatous mastitis. In this condition, this disease is also called granulomatous lobulitis, in which we can see multiple granulomas, actually non-caseating granuloma, seen in the within the lobules, and this granuloma, as we mentioned, is non-caseating. And non-infective inflammatory, under this term we have mammary ductectasia, we have fat necrosis, and galactose. In mammary ductectasia, it is common in perimenopausal women. The patient usually multipara and had been lactated, a history of lactation. It is also called plasma cell mastitis because of predominance of plasma cells in the inflammatory reaction, and its importance that it leads to a nipple retraction and can be mistaken clinically as carcinoma. Also, it can lead to a firm mass, skin dimpling, and can be mistaken clinically as carcinoma. Here microscopic picture of ductectasia. We can see here this is dilated duct and it is filled with eosinophilic materials rich in macrophages, and here we have periductal moderate inflammation consisting predominantly of plasma cells. So this is ductectasia. In fat necrosis, this is here the patient gives history of trauma, and it leads to clinically a firm hard mass, and this alone can be mistaken as carcinoma. It occurs in obese patients with pendulous breast. Here the type of necrosis we find in fat necrosis microscopically is liquefactive necrosis, and we can see a lipid laden macrophages and numerous neutrophilic inflammatory infiltrate. Here this is fat necrosis. We can see cholesterol clefts, and here the fatty tissue and the inflammation. Galactocele. Galactocele means cyst filled with milk, and it's commonly occur during lactation. It's important that there could be a secondary obstruction of the cyst, and this leads to a secondary bacterial infection and abscess formation. Now we come to very important subject in pathology, which is fibrocystic changes. Sometimes they are written in books as a fibrocystic disease, but actually they are not a true disease. They are changes. This may be related to hormonal changes. Generally, they are divided into two important types: non-proliferative fibrocystic change and the proliferative fibrocystic change. The proliferative type is more important than the non-proliferative because it can lead to carcinoma, or even it can coexist with carcinoma, especially if they are the cells are atypical. Fibrocystic change as a term, it is the most common cause of a breast lump, and it is important because it clinically can be mistaken as carcinoma, or they can coexist with carcinoma, or they may predispose to carcinoma, especially the proliferative type with epithelial atypia. Now we start with the non-proliferative change. Non-fibrocystic change means cyst and fibrosis. It is more common than the proliferative type, and we have two changes: fibrous stroma and cystic formation. Histologically, in smaller cysts, the epithelium is more cuboidal. We can see either flat or atrophic epithelium, or we can see columnar or cuboidal epithelium lining the cyst. But the most important is that presence of two layers. One is the epithelial layer and one is the myoepithelial layer. Presence of the myoepithelial layer is important for diagnosis of benignity. And also presence of apocrine metaplasia. Apocrine metaplasia is important for diagnosis of a benign breast lesion. In this metaplasia, we can see the presence of multiple cystic structures lined by polygonal cells, and the lining, the cytoplasm of these cells is granular eosinophilic, and the nucleus is round and hyperchromatic. These changes when the cells that lines a cyst showing abundant granular eosinophilic cytoplasm and round hyperchromatic nuclei, then we say this is apocrine metaplasia, and it is an indicator of benignity of the lesion. Now we come to proliferative change. In the proliferative change, we have epithelial hyperplasia, epitheliosis, or we have the glandular hyperplasia. We have adenosis. Epitheliosis is hyperplasia of the mammary ducts or ductules. This will lead to increased subsequent development, increased risk of malignancy, especially if the hyperplasia or epitheliosis is associated with atypia. Microscopically, we can see proliferation and there will be increase in the number of layers of the cells in the ductal epithelium, increase in the number of layers of ductal epithelium. In atypical ductal epithelial or atypical lobular, it can be atypical ductal or atypical lobular epithelial hyperplasia, and both are pre-malignant conditions. Here we have fibrocystic change. This is a gross picture. We can see multiple cystic structures, and here we have this gray whitish areas are the stromal fibroses. Here we have non-proliferative fibrocystic change. We have here multiple cystically dilated structures lined by two layers of cells. One is the epithelial cells, in which here we can see columnar epithelial cells, and the basal layer, which are the myoepithelial cells, which are important for diagnosis of benignity. And here we have stromal fibrosis between these dilated cystic structures. In proliferative fibrocystic change, we have a proliferation of the lining epithelium. We can see here multiple layers of epithelial cells, and we can examine carefully these epithelial proliferation, whether there is an atypical changes or there is no atypia. It is important because atypical proliferative fibrocystic change are pre-malignant conditions. So here we have proliferation, epithelial proliferation or epitheliosis, and here we have the fibrosis. This is apocrine metaplasia. It is important to see that these cystically dilated structures lined by large cells with abundant eosinophilic cytoplasm, and here we can see this is the abundant eosinophilic cytoplasm and a large hyperchromatic, although the nuclei are hyperchromatic, but these are benign cells, and this is an indicator of benignity of the lesion. Here the proliferative fibrocystic change, we see multiple cystic structures with epithelial proliferation and stromal fibrosis. Here we see papillary-like projections lined by multiple layers of epithelial cells protruded into the lumen, and these cells, when examined under high-power microscope, show an epithelial atypia, pleomorphism, hyperchromasia, high NC ratio of the nuclei of these cells. So these are atypical cells in proliferative fibrocystic change. This is pre-malignant condition. Now we talk about adenosis and sclerosing adenosis. Adenosis is enlargement of lobules and or formation of new lobules. Physiologic process, it can be either physiologic or it can be pathologic, which is part of fibrocystic change. In physiologic adenosis, we see that it's normally or physiologically occur during pregnancy and reproductive life. Sclerosing adenosis is an important subject because it can be mistaken both clinically and microscopically with carcinoma, because we can see proliferation of small glandular structures or acini or ductules, small ductules proliferated, and there is proliferation also of fibrous stroma. فهذا الفيتشرز انه اكو small ductules او acini in a fibrous stroma توحي انه هذا فد يعني invasion، توحي انه اكو malignant glands that invade the stroma and can be mistaken or diagnosed as a malignant, as an يعني ductal carcinoma by an experienced pathologist. Here we have sclerosing adenosis. We have small ducts or ductules proliferated. We have here a large number of these ducts, and we have stromal fibrosis. So this is sclerosing adenosis, sclerosing جاية من stromal fibrosis adenosis من هذه multiple small size glandular structures that present in these fibrous stroma. الفيتشر اللي تساعدني to indicate this is a benign lesion هو presence of myoepithelial cells line these glands. This is not infiltrative lesion, it is benign lesion. Tumors of the breast. Here we have three parts of tumors of breast. Two are the benign and malignant tumors. Both are originated from epithelial site of the breast tissue, and we have a certain type of tumor which is Phylloidus tumor. It's originated from the stroma and not from the epithelial component. The benign tumors include Fibroadenoma, Tubular Adenoma, Lactating Adenoma, and Intraductal Papilloma. Benign tumors, we have Fibroadenoma. Actually, Fibroadenoma is the most common benign tumor of female breast. لكن دائما نشوف Fibroadenoma during the puberty because it is estrogen dependent and it regresses after menopause. As we mentioned, the peak age of Fibroadenoma is around 30 years of age. Fibroadenoma grossly is a well circumscribed mass. If it is more than 10 cm, it is regarded as or it is called a giant fibroadenoma, and it is firm in consistency. Microscopically, fibroadenoma we have two components. طبعا fibroadenoma هو واحد من التيومرز اللي عندها يعني double origin اللي هو epithelial origin and mesenchymal origin. Microscopically we see two components for the tumor, which are the epithelial components اللي هي هذه عبارة عن يعني ducts lined by benign epithelium, single layer and a layer of myoepithelial cells, and the stromal components. Here we have the myxoid stroma, which is characteristic of fibroadenoma. The risk for malignant transformation in fibroadenoma is only 0.1% for all cases, and the type of carcinoma which originates is in situ lobular or ductal carcinoma. Tubular adenoma arises as a solitary well circumscribed firm mass which is tan to yellow in color. مشكلة tubular adenoma also can be misdiagnosed as an infiltrative ductal carcinoma because we have a small closely packed uniform ducts and presence in only minimum intervening stroma. Presence of these closely packed ducts يوحي إنه malignant glandular structures proliferation, and characteristically the stroma between these glands are only minimum. Lactating adenoma أكيد تصير عند البيشنت اللي هم يعني عندهم history pregnant women أو عندهم history of labor. A characteristic feature that can grossly this tumor be mistaken with malignancy is presence of necrosis. واحد من التيومرز اللي هي benign لكن بها necrotic change that can be seen grossly and mistaken for malignancy for carcinoma is lactating adenoma. Histologically, we can see a proliferation of glands lined by actively secreting cuboidal cells. أهم شيء يكون إنه cytoplasm of the cells is secretory cytoplasm because it occurs in lactating women. Intraductal papilloma, it can arise in large or small ducts. Histologically it's composed of multiple papillae. طبعا البابيلي هي يعني defined by WHO إنه هي finger like projections that protrude or project above the surface epithelium and contain a fibrovascular core of connective tissue and blood vessel. It's important to examine carefully the cells that line these papillae, and we should look for a presence of myoepithelial cells, because presence of myoepithelial cells is indicator of benignity of intraductal papilloma. So in intraductal papilloma we have papillary structures proliferation lined by benign epithelial cells and myoepithelial cells. This is grossly ductal papilloma showing area of hemorrhage. Stromal tumors, Phylloidus tumor, as we mentioned, Phylloidus tumor is a specific tumor of breast that it originates from stroma that is present between the tubules, or in the within the tubular structures of the breast. Actually, this tumor is not originated from pre-existing fibroadenoma, because fibroadenoma occur in young women, and the glandular structure is composed of two structures اللي هي glandular and stromal element. Phylloidus tumor occur in older age group than fibroadenoma, so it not originated from fibroadenoma. It is less common than fibroadenoma. Grossly, it is well circumscribed, and it can be lobulated and cystic, leaf-like with clefts and slits. Histologically, we have two components also. We have the epithelial component and the glandular component. The mesenchymal, the stromal component, spindle cell component, and the epithelial components. اللي يخليني أميز الفيلويدس تيومر عن الفايبروادينوما هو إنه overgrowth of the stroma over the glandular component. يعني الستروما كميتها أكثر من الجلانس تصير يعني السايز مالتها قليل، و يعني متباعدة. البريدومينانت تايب اوف تيشو هو الميزنكايمال تيشو spindle cell stroma. الانديكيتور يعني شلون اعرف انه الفيلويدس تيومر benign or malignant. We have four features that تخليني يعني presence of these features بدي افكر انه هذا malignant فيلويدس تيومر، اللي هي nuclear atypia, mitosis, necrosis, and overgrowth of the glands by the sarcomatous stroma. sarcomatous stroma يعني الستروما السيلز اللي موجودة بالستروما هي تكون spindle cells وتكون pleomorphic ويكون بيها mitosis، وممكن أشوف necrosis. هذه هي sarcomatous stroma. إذا هي البريدومينانت والجلاندز كلش قليلة بالتشو وأكو فد features of malignancy بهذه الساركوماتوس stroma اللي هي pleomorphism أو atypia وhyperchromasia of the nuclei، mitosis, atypical mitosis لازم يكون، وعندي area of necrosis, coagulative necrosis، أقول عليه هذا malignant phylloides tumor. Male breast, gynecomastia is enlargement of male breast, and it is results from estrogen excess. الحقيقة gynecomastia equal to fibrocystic change in female. Morphologically, we have hyperplasia of intraductal epithelium. We have proliferation of the epithelium within the mammary ducts. Clinically presents as subareolar swelling, and usually either one breast or two breasts. Here we have microscopic picture for gynecomastia. We have a proliferation of the lining epithelium of these ducts, and we have stromal predominance of the stroma. So we have proliferation of the epithelium and stromal proliferation. This is gynecomastia. Thank you.